Hello and welcome to the Addition Technology Intax and Intax XL training video. Addition Technology, global leader in corneal science and implant technology, is in constant search for new and effective technologies to improve keratoconic care. The Intax SK and standard intracorneal rings have helped improve the quality of vision for many patients and has delayed or eliminated the need for corneal transplants with great success. We have now developed the Intax XL corneal cross-linking therapy to enhance corneal stability by combining its performance with the success of the intracorneal ring. As a result of years of research, and with the assistance of Dr. Jimena Núñez at the Clínica Oftalmológica de Cali, we have created this demonstration video to guide you in the understanding and performance of the Intax intracorneal rings as well as the Intax XL corneal cross-linking procedures. Dr. Maria Jimena Núñez did her ophthalmology residence at the University del Valle, Cali, Colombia, where she also completed a fellowship in cornea and refractive surgery. She has a clinical practice at the Clínica de Oftalmología de Cali, Colombia, as a member of its cornea and refractive surgery unit. She is currently a professor at the Faculty of Medicine, Universidad Javeriana Cali, and she has been working in the Vision Sana research group for the past 7 years in ocular surface, corneal topography, diagnostic tests, and treatment for keratoconus. Addition Technology would like to thank the Clínica Oftalmológica de Cali and Dr. Jimena Núñez for their dedication, patience, and commitment to corneal science. Thank you. The Intax intracorneal ring procedure was initiated with the thorough face cleaning to avoid risk of postoperative infection. A preoperative prophylaxis is performed with povidone iodine at 10% for the eyelids and eyelashes. Afterwards, we apply 5% povidone iodine in the ocular surface for 5 minutes. In this case, we observe that the patient presents an asymmetric bow tie decentered with an oblique axis grade 3 2.82 cone with the steepest meridian at 136 degrees and the thinnest point of the cornea at 515 microns. With a positive KPI and CLMI for keratoconus. Preparation and inspection of all surgical instruments and tables is a step that should not be omitted. After inspection, we start with the incision placement marking at the steepest meridian with the Mendes marker ring. Afterwards, we proceed to verify centration corresponding to the geometric centering of the cornea in the case of standard rings at 7 millimeters or at the pupillary center in the case of SK rings at 6 millimeters. Once we've established the centering, we proceed to mark the area of incision, verifying at the opposite side to allow for proper balance of the site. The pachymetry is performed at the incision site. In this case, it is 657 microns. We then proceed to calculate the incision depth at 80%. The diamond blade is then calibrated to 0. For this procedure, the depth of incision will be at 520 microns which is 80% of the thickness of the cornea at incision site. The incision is performed from top to bottom and then to the top again in a 3-step movement. The Mpg hook is then used to open the tunnel at the incision site. The Mpg is introduced heel, toe, and then rotated to the left or right using an up and down movement to initiate tunnel entry. The Mpg is then rotated to the right or left and the same movement is performed. After this, we proceed with the symmetric glide, introducing it perpendicularly to ensure proper penetration of incision depth, and then following the corneal plane to ensure proper commencement of tunnel. We repeat this with the opposite side. With the pump off, the suction ring is placed on the eye to confirm the ring centration and incision site, at which time the pump is activated in low and the centering tools is removed. At this point, the symmetric guide is placed using it as a shoehorn for the dissector which is being placed. Once the dissector is engaged in the tunnel, the symmetric glide is removed. We place the pump suction on high and the dissector is rotated in 1 hour increments until the end. It is then removed in the same fashion, and the opposite dissector is then used to do the following tunnel. After we remove the suction ring, we will be using asymmetric SK rings for this patient. We first introduce the inferior ring after removal from its carrier. We apply moxifloxacin without preservatives on the ring in its carrier to avoid static movement and as a prophylactic. We proceed to remove any excess fluid and continue by introducing the ring with the insert forceps in the corneal stroma, entering perpendicularly to ensure it is being introduced at the correct depth, avoiding false tunnels, and turning with the corneal plane. The ring should be advanced from its distal portion. This final portion of the ring should be pushed with the Mpg hook. The same process should be repeated for the superior ring. Finally, a 10-0 suture is placed, which we prefer to secure to remove at 30 days postoperatively. We then proceed to verify ring centration with respects to pupillary center.